Welcome everyone to today's webinar on provider analytics technology, featuring key findings from Chilmark Research's latest report, 2019 Healthcare Provider Analytics Market Trends Report. I'm Hannah Enley, Chilmark's marketing lead and today's webinar moderator. Before we begin, I should note, we will include this webinar recording and the slide deck in our follow-up email. If you have any questions during the presentation or discussion, please submit them via the Questions tab in your GoToWebinar control panel that popped up alongside the presentation screen. We will address them at the end of the webinar as part of the discussion. Next, I'd like to introduce Chilmark Research. As an analyst firm, we are united by a core belief that effective deployment and use of IT is essential to modernizing care delivery and improving the patient journey. We monitor trends and developments in the industry with a focus on these technologies that will be transformational to healthcare delivery. We provide comprehensive, objective, high-quality research for busy executives. It's our way to help create a more informed, future-ready market of products and consumers. Leading today's webinar and presenting highlights from the report is Chilmark Research Director Brian Murphy. In addition to supervising all research at Chilmark, Brian's own research specializes in healthcare interoperability and analytics technology. With that, Brian, would you like to tell us about the state of the analytics market?
Yes, thank you very much, Hannah. You should be seeing an agenda for what we're planning to cover today. I'll spend a little bit of time just kind of describing, I should say that this webinar is based substantially on a report that we issued not too long ago on healthcare provider analytics. So I'll spend a little time describing what the report's about and its scope, etc. Then I'll kind of dive into the technology that we're seeing being deployed by healthcare provider organizations. I'll talk about the vendors that are participating in this market. This report describes the offerings from 23 different vendors. We talked to probably 35. Some did not sort of meet our kind of minimum criteria, but I should also mention that there are vendors out there who are not in this report, who we weren't able to talk to for one reason or another. So while we think this report is pretty comprehensive, I think at this point it's impossible to capture the variety and the strength of different of all the different vendors that sell into provider organizations. Then we'll kind of wrap up with our vendor ratings, which is the first time we've done this on a webinar basis. Normally that's something that's only available to people who buy the report. So this report really, this is based on a report that we've been doing, I think, for 7 years. Originally, the title of this report was called Clinical Analytics for Population Health. So it focused exclusively on the use of analytics in kind of value-based care type arrangements. This time, we expanded the scope to include the use of analytics for essentially any purpose inside of provider organizations. We looked at companies that have end-user functionality, at least 2 live customers and at least $1 million worth of revenue. And I got to emphasize that all the vendors who ended up in this report, for the most part, kind of blew by those metrics. Every vendor in this report is a pretty serious player with satisfied customers. So from that standpoint, the criteria I think it's kind of a low bar. The emphasis here is on offerings that have end user functionality. Many of the vendors that we talk to do lots of other things, and in particular, a lot of these vendors have strong data aggregation skills or tightly coupled their analytics to, say, a care management application. In both those cases, whether it's data aggregation or care management, that's kind of out of scope in terms of this particular report. We will be covering those areas in other reports later this year. We kind of bucketed the vendors who appear in this report in kind of three categories. There's conventional claims analytics vendors, and I'll talk about that. They've had a very not a simple time selling into provider organizations. There's EHR vendors who have done quite well here, and independent vendors. And by independent, I'm referring to vendors who are completely independent of EHR vendors and completely independent of any payer entanglement. These are some of probably the most important takeaways. Despite the fact that this report has to do with, we took an enterprise view, so we looked at the use of any potential use of analytics inside of a provider organization. We still think that value-based care is kind of the primary business driver. We think that organizations are adopting analytics technology often initially in order to get a handle on how they're doing or how they could improve with respect to value-based care arrangements. The dominant way that this stuff is delivered to end users is through reporting and dashboards, and I think it's fair. You will often hear people say that nobody needs another report or dashboard, and while I can certainly sympathize with that observation, it does appear that there still is strong demand for new reports and new dashboards. After having looked at kind of the breadth of what's out there and what people are doing with it, I don't think it's hard not to come away with the idea that these are sort of early days in terms of analytics in healthcare provider organizations. It was not too long ago that EHRs were a new and radical idea. So I think particularly with smaller organizations who are just kind of getting their legs under them in terms of using IT, these applications were kind of a revelation. And I do think that that really did is kind of open people's eyes to what you could do with these kinds of tools. So just a long-winded way of saying I think there's more opportunity to do more things with a lot of these products than people are currently doing. So let's talk a little bit about the technology that we see across vendors in general. We have sort of arbitrarily divided the world into two here. There's mainstream analytics and advanced analytics. And mainstream analytics is really just the idea of identifying data sources, putting it into some sort of a relational data structure, and using that to generate reports and dashboards. And that represents really sort of 90% of kind of what people are doing with analytics. You hear quite a bit about advanced analytics. And this is it's not a super well-defined set of capabilities, but in general, when people talk about advanced analytics, they're talking about AI and ML, possibly NLP, and possibly big data or NoSQL type databases. In terms of what mainstream analytics does, it's primarily but not exclusively descriptive. It enables people to understand performance based on past data, so they can understand where they are and then change their processes to perform better in the future. But mainstream analytics does have some ability to predict things. I'll talk about that in just a second. And in fact, it can recommend specific actions. And probably the simplest example would be actions that a clinician would have to do to improve quality performance. So when you push a care gap to a clinician, that's prescriptive, whether you like it or not. These are some of the use cases that we're seeing implemented using mainstream analytics. Obviously, as I said, value-based care is, in addition to being kind of the primary business driver, every single vendor in this report has value-based care use cases. These are usually tied to one or a number of payer contracts, and they provide kind of quality, cost, and utilization performance management capabilities. But the range of other potential use cases is fairly broad. It's pretty commonplace for analytics to help provider organization understand what's happening in their clinical areas, whether it's patients moving around a hospital, understanding where referrals are coming from for a primary care practice, where referrals are going. We're seeing increased interest in safety analytics. A lot of that has to do with infection control. But the range of use cases that we saw across these 23 vendors was incredibly broad, and no two vendors has quite the same set of applications. Just want to spend a moment talking about how VBC is done by these vendors. The most common use case essentially the idea is on a per contract basis, and we're seeing vendor products that let users kind of toggle between payment contracts. So they could click their MSSP program and see information about patients who may be in that MSSP. They could click to DSRIP and see a different group of patients. They could click to a P4P type program and see yet a different group of patients. The clinical quality metrics are kind of the dominant way of sort of organizing data. In other words, and there's usually a very strong organizational hierarchy, kind of navigational way for people to use these applications. So they provide clinical quality information. Usually patients are also risk bucketed. Along with clinical quality, provides cost and utilization data, and leakage and benchmark data. So and these two are sort of related. So when somebody goes outside of a network, obviously they're seeing other organizations. So and almost every kind of VBC-oriented product provides some measure of will provide cost and utilization data for out of network for things that happen out of the network. Some will also provide information about the quality that's happening in that out of network type environment. The information is usually presented as a standalone report or dashboard in a portal, web app in a portal. Increasingly, it's embedded in the EHR in two different ways, and I'll talk about that in just a sec. Or care management application. Data is generally tabular, or along with a lot of graphic displays, and GIS coding is far more common than it used to be. Just a word on data sources. So the EHR sourced and claims data are far and away the most important data sources for these applications. Several years ago, combining these two sources was kind of a challenge for a lot of organizations and their vendors. We feel like the industry has sort of turned a corner on this, which is not to say that it's necessarily simple, but it does seem like people understand what the challenge is. I kind of really feel like this combination will be important for quite some time to come. And the usual sorts of data management challenges that you see in healthcare in terms of patient matching, ensuring that data is uniform enough to be computable, ensuring that the data that's available to the applications has a high enough quality level so that it's that people can trust what the output is. These are continuing challenges, and so We are also beginning to see more and different kinds of data being used in these applications. People have been talking about social determinants for quite some time. We are seeing that become kind of more of a more prominent additive to these analytics data stores. A lot of vendors are talking about putting like a lot more automation into their ETL processes. I think if there's a qualification on this, I would say that depending on which vendor you're talking about, the right combination of data and transaction types may or may not be in scope. So we showed earlier that mainstream analytics is good at describing what has happened. Mainstream analytics is pretty good at making some predictions, and these are examples of things that most of these products do in one way or another. There is, for the most part, a lot of these predictions they're kind of proprietary with respect to the vendor. Readmissions risk, there's a lot of different standardized kind of industry accepted ways of doing this. Well, accepted is too strong a word. There are sort of dominant methods, but a lot of these sort of predictive things, there really are no kind of uniform ways to do it. So the vendors end up doing these things using their own algorithms. So advanced analytics is a topic that we hear quite a bit about. It's a term that people use as if this was an actual category, which I guess I'm suggesting is an actual category, more an actual category to be. Natural language processing is that's been around a long time in healthcare, extracting data from unstructured data sources. It has a home in clinical documentation improvement, coding assist, stuff like that. More and more vendors are beginning to use NLP to extract data from notes to add to these analytics data stores, but it's certainly far from being uniformly available at this point. Big data or NoSQL type database systems, I think, are pretty widely used by these vendors, and they are primarily used during their ETL processes. And my sense is that these implementations provide, these kind of NoSQL type options provide some scale and efficiency advantages for the vendor. It's not at all clear that the provider organization, the customer, necessarily sees any direct benefit, but I think it certainly does make the vendor's data management job a little bit easier. Artificial intelligence and machine learning is another something you hear about quite a bit. For the purposes of these kinds of applications, you mainly sort of see it for kind of fairly narrow uses. At this point, it's not a major contributor to better reports or better dashboards, but we do think that this is an area that's poised to grow significantly over the next 3 to 4 years. So these are examples of some of the questions that advanced analytics could answer that, frankly, kind of mainstream reports and dashboards don't. Things like what's going to happen with this, what are the possible courses of illness for this particular patient, given the data that we have on hand. What kind of in a given clinical, a clinician could say, given a certain patient situation, are there interventions that I could use that I'm not thinking about? So advanced analytics could make those kinds of suggestions. Letting a clinician understand the possible outcomes from different interventions on a per patient basis is something I think that people would jump at the chance to use if it were available to them. Understanding kind of what's going to happen to a patient once they're once they've moved to a different venue or once they're no longer in your care, is something that advanced analytics could make a major contribution to. I've got 2 slides here just to kind of give people a general sense of the availability of applications across different venues and for different kinds of uses. So we for the roughly 30 vendors or so who answered our questionnaire, as I said, only 24 ended up in the report. We kind of tallied up who said yes and who said no to a questionnaire that kind of followed this format that you're looking at right here. So we saw, I'm going to hop back and forth between 2 slides here, so just bear with me. So we asked this about inpatient and we asked it about ambulatory. The colors essentially correspond to general availability or the availability of applications in each venue for the kind of use case. And the reddish, the warmer colors mean lots, and the cooler colors, the blues, mean not that much or in some cases none. And you can see, in general, there are a lot of applications for hospital type venues, probably more so in ambulatory than anywhere else. I think a lot of that has to do with, as I said, this whole idea of population health is relatively new. There was a whole raft of new applications, or a lot of the initial population health type programs were geared towards primary care. So we tend to see more applications geared towards the needs of people treating patients in primary care. So it's unsurprising that we see this sort of ambulatory as kind of a hotspot. This is mirrored when we look at kind of ambulatory venues. There's plenty of applications in primary care. Not that many primary care and specialty care, relatively less in outside of those venues. We see hospitals and health systems are obviously trying to extend their application portfolios to some of these other venues. It's not clear that it's kind of reached the point where they're beginning to offer analytics to other kinds of organizations in their communities and catchment areas. And I think that this sort of reflects that. So before I kind of get into the vendors in particular, I wanted to spend a little bit of time talking about how people use these things. So I want to talk about kind of different users and kind of the intensity with which they engage with these applications. And then I want to talk about I have a second slide that talks about the actual options for consuming this information. In other words, what can you put in front of any one of these users to, so that they can kind of understand what is happening. So developers and analysts obviously are concerned with building these applications or enhancing these applications. The decisions that they make really contribute to the success of an overall program. People who are miners, the miner scanners and sippers here are really sort of more true end users. Your miners are your typical super user. These are people who really dig into the data, really understand it. They'll start out using some kind of fairly detailed dashboard and soon decide that they need more. And they're kind of looking across the whole spectrum here. They help build, they also consume. Most of the decisions that they make contribute to the success of the program in general. Scanners and sippers are your typical end users. Scanners are, say, supervisory people who kind of consume this information. They have some ability to make personal decisions that directly affect how a performance improvement program is going to work. But they also contribute to decisions about they can act either at the program level or they can act at the patient level to contribute to the success of a program. Sippers are people who, for the most part, probably aren't interested in reports and dashboards. They're interested in the most summarized information possible. These are the people who probably have the most impact overall on performance improvement programs. When you look at that sort of those different kinds of users, this is sort of what they get to work with. Over on the left here, we have actual printed reports, and all too often, that's actually what happens. Reports get printed out. They get put into face sheets before, so that physicians can, your primary care physician, SIPR, can kind of look at them before they go into an exam room for an encounter. They get talked about at morning huddles. So there is this sort of analog aspect to how these things end up being used. And everything else, reports, dashboards, blah, 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 this stuff all happens online. So we see a lot of PDF reports being distributed. Most of them are static. Some of them are clickable so that they're dynamic. Information is kind of distributed at either a summary level or a detail level, depending on who it's going to. The next step up would be an actual dashboard, which is intended by its very nature to be more interactive than a PDF report. These are almost invariably delivered as a web app inside of a portal. They support both summary and detailed information. So vendors ideally would like to put the results of analytics directly into the EHR so that when a patient's chart is opened, anything that clinician needs to do, so by the way, care gaps or coding gaps or whatever it might be that comes out of these analytics, it would be instantly apparent to that clinician based on what they see on the face sheet page in the EHR. But an interim step is this idea, and we're seeing it far more than we did, say, 3 or 4 years ago, that when the patient's chart is open, a window opens up kind of right next to it that's linked to that particular patient, and it essentially pushes the same kind of information that I just talked about with respect to the EHRs. But it's more common than it used to be. It's not universally available, but it's increasingly available. Before I talk about the vendors, I just wanted to say a brief word about the 21st Century Cures Act. For people who, the 21st Century Cures Act did a lot of things. One of the things it did was outlaw the idea of information blocking. There's been a lot of congressional hearings on this. It's kind of a big deal. ONC has been working on a proposed rule that would implement the information blocking provisions in the 21st Century Cures Act for a while. They just issued their proposed rule Friday before HIMSS. It has generated quite a bit of discussion and concern. It has 2 provisions that I think are directly related to these kinds of products. It sets up this thing called EHI export, which is essentially the idea that a patient should be able to get any information about any of their information from anybody who's holding it. The other is it requires providers to set up APIs to make data accessible via API. The EHI export requirement is very broad. The API conditions of certification requirement is much narrower, but the EHI export could apply to anybody. Quite honestly, the API conditions of certification requirement only applies to people who have or have had certified HIT. This is a very important development. The comments right now are due to ONC by May 3rd, although there's already talk about, there's huge pressure on them apparently to extend that by at least a month. Just before this webinar, I got an email from ONC saying that they had set up an enhanced way to submit comments on this proposed rule. So I have a feeling that they're getting a lot of response. So let's talk. I want to turn to the vendors right now. So let's talk about them for just a sec. This is essentially a list of all the vendors who appear in this report. We bucketed them into three different categories: EHR vendors, independent vendors, and claims analytics vendors. Independent vendors are not owned by an EHR company or not owned by a payer. Some of those claims analytics vendors that you see here are actually owned by a payer or have an owner of some kind who is a payer. I just wanted to say a word about a distinction that exists here. It's not a hard and fast distinction. When you look at the total portfolios of each of these vendors, they are often either kind of general purpose or special purpose. And a general purpose portfolio would be essentially a kind of a single sort of a platform type offering that supports lots of different use cases. They tend to have big data catalogs. Every user seems to have a very large number of filters available to them to support, so that they can kind of dig into their data. In general, the general purpose type offerings let you go deeper, provide more different ways to segment populations. The special purpose kind of approach is generally geared to a VBC or P4P or some other performance improvement program. And the whole idea is for the application really to drive better performance. It usually has a quality quality is sort of the primary metric, but they certainly provide cost and utilization data. There's often a very strong association between the analytics and a care management program. And in fact, the care management program is really about operationalizing performance improvement. So there is this kind of distinction. Many of the vendors in this report I would characterize as kind of special purpose, but there are plenty that are general purpose, and the vendors who have sort of more general purpose type portfolios do many of the special purpose things pretty well. So let's talk about the three different categories of vendors. The EHR vendors, they are strong, but they also, with a handful of exceptions, do not sell anywhere but inside their own EHR customer base. Most of them, not all of them, I would call kind of general purpose. So they do have pretty viable product offerings across multiple domains. I think in their heart of hearts, every EHR vendor would like to be a one-stop shop for analytics. That is there's no example of an EHR vendor that hasn't experienced some level of competitive encroachment. So the independent vendors are doing really well inside these. They're giving EHR vendors a run for their money. The EHR vendors, I think, have the advantage in terms of their proximity to day-to-day workflow. They tend also not to be providing lots of services that are not directly related to IT and data. It's sort of common for the EHR vendor to offer data scientists. For the most part, that seems to be they've got people who can kind of go in and get more out of the data that's there. They tend not to be so strong at providing more kind of strategic services. So helping a healthcare system decide whether or not to be in a particular risk-sharing type of arrangement is not something you would ordinarily find an EHR vendor involved in. The independent vendors. So in general, they tend to have, I think, a little bit more to prove than the EHR vendors. Their implementations tend to be fairly quick. I think sometimes they can be out in front of market demand. We've seen independent vendors, for instance, who put together tremendous programs for, say, bundled payments, where there's not a lot of market demand for something like that. Over the course of probably 6 or 7 years, we've seen independent vendors fall by the wayside, so there has been some attrition. They have arguably the strongest offerings for value-based care. They're trying to get closer to the EHR in general. Their product catalogs tend to be more limited than EHR vendors, but there are 1 or 2 independent vendors who have extensive product catalogs that are competitive with any EHR vendor. I think one of the things they're really good at is understanding causation. So if you're looking at a particular quality metric, you can really dive into the patient population that's relevant to that metric and understand what's driving risk. You can really understand. You can use these products to get a good handle on what's happening inside of cohorts. Payer-oriented vendors use exclusively claims data. Claims data is their most important data source. A lot of these vendors have not necessarily done really well with providers. Providers, I think, are reluctant to adopt these products because they're so closely associated with payers. But it's pretty amazing to me when you kind of see how these things work. They provide really deep exploration of the data that they've got available to them, and it's a kind of a different way of looking at things. I'm scratching my head as to why more providers aren't adopting these things. They also offer most of these companies tend to offer different kinds of outsourced services. So they go well beyond kind of IT and implementation and help people, I think, with services that make a performance improvement program successful. So I think, So as I said, there's 23 vendors in this report. We looked at we're analysts, so we have to say good, bad, or indifferent with respect to each vendor and what they're offering. We broke down everything, all the functionality that we saw into these sort of general functional categories here, which are called product capabilities criteria. We also looked at kind of how each vendor sort of brings their offering to market. And the upshot of looking at all of those things is this, which this is our Chilmark bearing. As I said at the beginning, every single company on this chart, regardless of their grades, is a serious player. So we feel like a tool like this we put together is a good place to start. Any provider really needs to evaluate any of these companies and their offering in the context of their own requirements. So, conclusions. Over the last 5 years, I really think that these applications have come a long way. They're easier to use. There's more of them. I really feel like this particular group of vendors has done a good job of kind of moving the ball along. There are some things that are still missing. We don't really understand much about care coordination. In general, the proliferation of quality metrics it's a problem, and whether these quality metrics really contribute to better quality care is a fit topic for debate. So that exists. These products in general are not especially good at modeling, so you can't say, oh well, we want to improve our performance in the following 6 metrics 25%, and tell me what that will mean in terms of revenue, tell me what it will mean in terms of costs, tell me what it will mean in terms of resource utilization. Things like that just don't exist. So these things tend not to provide too much visibility into whether a healthcare organization, it's the impact of performance improvement on profitability. So that's kind of a gap. So that kind of brings us close to the conclusion. I just want to emphasize that this was the first of 2 reports that we're going to do this year, provider analytics. Before early summer, we are hoping to put out a payer version of this. We've already talked to most of the companies. We're still talking to a few. So that will be coming fairly soon. So Hannah?
Thank you so much, Brian. We have a few questions waiting for you. First, let's go over to the recent proposed rules. Sherry Duville is wondering, are there any obvious and superior benefits to the documented-oriented interoperability over a methodology based upon document elements, i.e. FHIR? And will focusing on TEFCA and documents slow down migration to FHIR?
So, well, I guess I think sort of embedded in that question, I think, is the idea that FHIR is intrinsically superior in all circumstances, and it's not. FHIR is certainly going to help the industry in lots of different ways, but I'm not sure that it is. It's certainly not going to replace a lot of a lot of how people are exchanging information between different organizations and between applications. I will say that these, so these reporting and dashboard type applications are heavily dependent on batch processing, and that's done in so many different ways it's almost impossible to enumerate them. It's done through direct database access, so a lot of these vendors have access to EHR databases. It's done through FTP, so for instance, all the claims data usually comes into the provider organization via FTP. They will, many of the vendors rely exclusively on CCDAs. So documents, and they will process millions and millions of CCDAs every month to extract the data they need to put together their applications. So I think the reality is FHIR will take its place as one of the ways to get at data, but I think that the challenge for vendors is they have to really be able to adapt to the variety of different ways that data is represented and a variety of different ways that people get to data in order to really be successful.
Thanks, Brian. How much of a role will business intelligence tools play in this market?
So yeah, business. I'm not sure I even said the word, but third-party BI tools are really important in this market. There are a handful of offerings that are built exclusively from third-party business intelligence tools. So every single vendor that's in this report generally makes their data available to third-party business intelligence tools. So for the foreseeable future, these will be a tremendous tool for both analysts and for super users to kind of build new reports, new visualizations. Is there a lot of use of analytics by scanner and sipper user types? And do these products emphasize those users relative to other types? And are the offerings strong for those users, scanners and sippers? So scanners generally are going to look at reports. Sippers, so these are not hard and fast categories. I should just, these are descriptions that I dreamed up. The idea of a sipper is someone who probably doesn't really want to look at a report or a dashboard. They would prefer to get information either in their EHR or in whatever application it is that they're using kind of full time, and be told just what they have to do in order to further the goals of the particular performance improvement program. So scanners, they're people who are kind of looking at reports, but they're not, they're not living and dying by these reports. What they're interested in seeing is that there's improvement over time. Hopefully that answers the question.
Okay. And then speaking of those day-to-day reports, how are AI and ML algorithms contributing to those reporting applications?
We're not seeing a huge amount of, say, algorithms embedded into the stuff that people are using day to day. Now, there are certainly plenty of instances where that could be happening behind the scenes, but the challenge here is really about kind of organizing data and presenting it in a way that's meaningful to users. And we expect AI and ML to contribute to that more, but for right now, it's a relatively minor contribution.
Okay. Moving on to the vendors, were the large EHR vendors evaluated for their general analytics platforms or for the targeted VBC analytics solutions?
So if you look at the list of capabilities that's in the presentation, there is we evaluated all vendors using the same criteria. So the EHR vendors are kind of stand in the same stead as the kind of independent vendors. I will say that given this sort of healthcare enterprise focus, I think EHR vendors did better in some respects, marginally better than the independent vendors. But everybody was evaluated using the same criteria. But that said, I think that the independent vendors probably have an edge in terms of VBC.
Okay. What functionality did you see that didn't quite make it and isn't quite mature enough to be included in this report, but we should keep an eye out for in the coming years?
I think I may have come across here as poo-pooing AI and ML, and I think that that is going to make an impact. It's not clear it's going to make an impact in terms of the applications. I guess if I had to guess, I think it's going to have a bigger impact on ETL and taking data from wherever it was created and rendering it into something that's computable and usable for these applications. I do think that there's I think there's a lot of opportunity there.
Okay. Was interoperability across the vendors analyzed? Are all vendors equally open to playing nice for the benefit of the provider and I suppose patients and or payers as well, depending on what kind of vendor?
So I think the short answer is probably no, but here's the reality. So there's 24 vendors. They've all got X number of provider customers. What is clear is that those vendors get access to the data that they need. Now, I'm sure if you got them in their private moments, there'd be things that they'd like to see better access to. But I do think if a provider decides to go ahead and implement one of these products, they're going to make, they are the ultimate arbiter of who gets access to what data. So I think that it's intrinsically the relationship requires the cooperation of the provider organization. Obviously, for bigger organizations, that's a bigger deal. For a 200 doctor practice, it's kind of a non-issue. So I would say that the providers are willing to be as interoperable as they have to make these applications work.
Thank you so much. We appear to be out of questions, but if you think of any more, so we're going to finish up. So if you have any other questions for Brian that comes up as you're reviewing the slide deck maybe or talking with your colleagues, feel free to email Brian. His email address is on your screen. And in a few days, I'll be following up with the recording and the full slide deck for you. For more information on the market for the report, or on the market for analytics solutions and just a deeper analysis of some of the IT tools we started to visit, I encourage you to check out our new report. I'll include the link in the slide deck in my email. And again, if you have any questions for Brian, feel free to email him. Thank you so much for joining.